This talk is entitled, How Can We Improve, or I would say it better, how can we help PGS programs with vitrification? So vitrification has become the standard procedure for oocytes cryopreservation because it works much better than slow freezing. And regarding embryo cryopreservation, it is true that with slow freezing we had quite efficient cryopreservation programs. With vitrification, the results have also improved greatly thanks to vitrification. As a consequence, there is an increase in the frequency of cryotransfers in all group of ages, and also the number of babies born after cryotransfer has also increased lately. And in the same way, the use of autologous vitrified oocytes has also increased. So what is the reason? The reason is, as I mentioned, we have better technology, so we feel more confident in our cryopreservation program, so we use more this approach, which has allowed the introduction of different treatment strategies. For egg banking, of course, we have this approach for ovum donation, also for fertility preservation, and for the management of different clinical situations, which we are not discussing today. Regarding embryo banking, as we have such an efficient cryopreservation programs, we can, let's say, more safely afford the single embryo transfer because we have we are completely confident on the survival of the surplus cryopreserved embryos. It has also allowed the introduction of the freeze-all strategy to discontinue the fresh transfers or to help in other situations, like in cases of high progesterone levels or the risk of OHSAs. And as an adjunct to PGS programs, which is the issue of this talk. So we demonstrated back in 2012 that vitrification worked very efficiently in different embryo developmental stages from day 2 to blastocyst stage, including day 5 and day 6, with slightly lower outcomes in implantation rate in day 2. This table summarizes different studies from the last 3 years, including a cleavage stage vitrification and blastocyst vitrification using different vitrification devices, open or closed devices, and different methodologies for vitrification. And as you can see here, the survival is quite comparable and very high. So the summary is that embryo vitrification, cleavage stage, or blastocyst stage is working very well with different vitrification systems. So with this such good results, it was introduced the segmentation of IVF concept. This is a meta-analysis published in 2013 by Roque, concluding that in terms of ongoing pregnancy rate and clinical pregnancy rate, it was better to do the freeze-all strategy, to cancel the fresh embryo transfer and to do all the transfers in a subsequent cycle. However, I have to say that these couple of studies, included in this meta-analysis, the one from Aflatunian and the one from Shapiro, there is controversial. These papers have been contested because of serious flaws in the study design. So what I can say, or what we could say so far, is that the truly utility of the freeze-all strategy is yet to be confirmed. I mean to discontinue the fresh embryo transfer. But there are some cases, as I said before, in which this strategy is useful. And these cases I just mentioned, we are not going to talk about this today, but as an adjunct to PGS program, we can either accumulate oocytes or embryos in cases of low, in low responders, as Maria Eugenia mentioned in her talk, that usually, at least in our hands, our PGS patients, they are advanced maternal age patients, usually low responder patients. So we have been using this strategy, and I'm going to show you the results afterwards. And we can also vitrify the embryos or the oocytes after the biopsy. So this is what we are discussing today. As summarized by Simadomo in this very recent review, with also Antonio Capalvo and Laura Rienzi, our co-workers in this study, and as all you are aware, these are the different stages for biopsy: polar body biopsy, cleavage stage, and trophectoderm biopsy. These black arrows shows the drawbacks of any of these strategies, and the black arrows, according to these authors, shows the advantages of each strategy. So from first glance, you can, I don't know if you can see this, but it seems like trophectoderm biopsy is the most, the one showing the highest number of advantages. But this is not really my subject, so I'm not dealing with this. So let's evaluate the vitrification, the application of vitrification in these different strategies. So the first one was the polar body biopsy. This study was published by Sher and co-workers in 2008. And as shown here, survival after warming, after the biopsy of the first polar body, was 97%, and with a very nice blastocyst formation, 65%, with quite high implantation rate, 61%. This time, these authors used only the euploid first polar body oocytes. On the contrary, in the next one, and this was published in 2015 from Grifo and co-workers, this was the study design. They did the first polar body biopsy and then vitrified the biopsy oocyte. After warming, they microinjected all of them, the euploid polar body biopsy oocytes and the aneuploid polar body oocytes, allow them to reach the blastocyst stage, did the TE biopsy, and transfer the fresh blastocyst, of course, euploid blastocyst, and then the surplus blastocysts were vitrified. By the time of the publication, the clinical outcome was only from the fresh blastocyst fresh euploid blastocyst transfer. So what is interesting for us in this talk is all the stuff related to vitrification. So survival after the polar body biopsy was 87%, which is also a good outcome, yeah, and it's comparable with different publications. And the blastocyst formation from euploid polar bodies was higher than from aneuploid polar bodies, which is somehow expectable. And the number of, was the number of euploid blastocysts, but there is a 15% of aneuploid polar body oocytes which generated euploid blastocysts. So as shown by these authors, this is not really a good option, the biopsy of the first polar body, because the predictive value is not good. It's very high. And this is also very high, which is the in which we are interested. Another approach is, instead of do the biopsy and the vitrification, is the accumulation of oocytes, of M2 oocytes from different stimulation cycles in low responders, which are usually PGS patients. So we published this in 2011. 12, sorry, and in different groups of ages, but especially in older patients, older than 40 years old, we showed that the transfer cancellation was greatly lower than in the group of patients doing fresh cycles, only fresh cycle after fresh cycle. It means that if we accumulate oocyte, then the probability to have an embryo transfer is higher because we have a larger cohort. This is quite obvious. And also, the live birth per patient was twice the one achieved in patients without accumulation. These were not PGS cycles, just low responder patients. And this is we've been applying this since 2007 when we introduced the vitrification program in our group. And this is the evolution of the survival rate over these years. And as you can see, it's quite stable. It's quite reproducible, the technology. But what is most interesting to my point of view is the efficiency as analyzed between fresh and vitrified oocytes. And remember, those are oocytes from the same patient inseminated simultaneously in just one ICSI cycle. So we have the opportunity to evaluate embryo development from fresh and vitrified oocytes. So this is what we are doing here. And for efficiency, we are counting on the percentage of embryos that were transferred and that were cryopreserved. So those good embryos developed from the different vitrified or fresh oocytes. And as you can see, it was calculated per injected oocyte. And as you can see here, the efficiency is quite the same and consistent. But you need to keep in mind that this was calculated per injected oocyte. If we calculate this per initial M2 oocyte, then the efficiency will be lower in the vitrification group because survival is not 100%. So this is something we need to consider. So we applied this technology. This was published in 2010 by Miguel Milan from our group. And it was not exactly the same approach because this time in the group of accumulation, they were only vitrified cycles, vitrified oocytes from different stimulation cycles, no fresh oocytes this time. And as you can see here, if we compare accumulation versus low responders, no accumulation, again, the percentage of embryo transfer was higher. So we are increasing the probability to find euploid embryos to transfer with this approach. Now I'm going to show you some data from, this is from Pilar Buendia from our group, and this is her doctoral thesis. And it is PGS cycles, but analyzing, as I mentioned in the first study I just showed you, fresh versus vitrified oocytes after accumulation. So again, the same study design, the ICSI, day 3 cleavage stage. We did the biopsy on day 3, and then allow them to reach the blastocyst stage, the CGH analysis, and of course the transfer of the euploid blastocyst. So again, we had the opportunity to compare the outcome between fresh and vitrified oocytes from the same patient, same ICSI cycle. So the mean age in this study was 4.7. Survival rate was 81%. So as we lose some oocytes, the mean number of metaphase 2 oocytes to microinject was lower in the group of vitrification, fertilization rate was comparable, and as a consequence, we have less oocytes, so the number of embryos to be biopsied was also lower in the group of vitrification, but what is most interesting in my opinion, is that the euploid the blastocyst formation was comparable between fresh and vitrified oocytes, and that the euploid blastocyst calculated per both injected oocytes and initial metaphase 2 oocytes were comparable between fresh and vitrified oocytes. So we would expect a lower rate of euploid blastocyst in the group of vitrification. So I think, and this is a guess, hypothesis, that what is happening here in the vitrified oocytes is that vitrification somehow operates as a filter. So those oocytes that were not probably bad quality oocytes, because those were aneuploid oocytes, did not survive. So all those that survived were the good ones. That's why the euploid blastocyst rate was comparable between fresh and vitrified oocytes. This is the analysis according to each chromosome between fresh and vitrified. We had a higher proportion of aneuploidy for sex chromosome in the fresh oocytes, but this is totally anecdotal, sorry. And this is also very interesting information. We did a logistic regression analysis trying to find out if the origin of the oocytes, fresh or vitrified, had any impact on the probability of having at least one blastocyst, one euploid blastocyst, and the probability of achieving the ongoing pregnancy rate. And as you can see here, there is no any impact of vitrification. So this is I think the most relevant finding of this study, that vitrification does not impair or is not inducing a higher aneuploidy rate, vitrification of oocytes, of course. But you may be thinking, why only oocytes? We can also accumulate cleavage stage embryos. And Lorena Rodrigo from our group as well just answered this question in 2014, showing that when we accumulated oocytes, day 2 embryos or day 3 embryos, and we compared aneuploidy rate, pregnancy rate per transfer, implantation rate, and miscarriage rate with fresh cycles, there were no differences. So the answer is, it's up to you. You can accumulate both oocytes or embryos. I have to say that today, or these days in our clinic, we are accumulating embryos because of the survival rate is 80 to 85. Sometimes the patients they count on the oocytes they have vitrified, and then we say sometimes none of the oocytes survive. So it's kind of difficult to explain to the patients, while we are vitrifying embryos and survival is higher, and it's a better approach for us. But you can do whatever you want. So the second stage of biopsy was the cleavage stage, and this is data of survival from cryopreserved biopsied embryos by the slow freezing procedure. And as you can see here, survival was very low, basically because when we cryopreserve the oocytes, the blastomeres, biopsy the oocytes with the hole, the blastomeres just escape the zona pellucida and the embryo is gone. There are some improvements in the slow freezing protocols, and so some authors, they improve the survival rate here and here, but still Those are embryos, and survival rate is of course not enough. We are losing 30% of embryos. This is low freezing, and this is for vitrification. This is a study from Shang, was published in 2009, and they compared cleavage stage. All of the groups were vitrified, or all of them are vitrified embryos, but non-biopsied, biopsied at the cleavage stage, morula, and blastocyst stage. So as shown here, vitrified, biopsied, cleavage stage embryos survived in a lower proportion than the controls. So again, this is happening with vitrification as well. So it seems that to cryopreserve biopsied early cleavage stage embryos is not a good option. And this is in this case, I don't have any explanation as well for this, and the author didn't. It was better the survival in the biopsied blastocyst. And again, the blastocyst formation when we vitrify early cleavage was comparable. I mean, in the cleavage stage and the morula stage, it means that if they survive, then they are good and they develop to the blastocyst stage. But as I mentioned, this is not really a good option. So the trophotoderm biopsy and vitrification. It was one of the first studies showing this was published by Schoolcraft in 2010, and by this time it was I don't remember well, but it was a not so high sample size. But all of the blastocysts 100% survived for this study. So it was quite encouraging for everyone to take this option. So I'm going to share with you some data from our group. As Maria Eugenia said, we are moving to the TE biopsy, but we are very good with early cleavage biopsy. We've been for years doing the biopsy on early cleavage embryos, and now we are moving to TE and are doing quite well as well. So this is quite low sample size, 86 PGS cycles, 402 blastocysts, mean age 37.9 years. And in 93% of these cycles, we were able to do the TE biopsy. So we did the biopsy, and we vitrify the biopsied blastocyst within an hour. It doesn't mean 1 hour. We usually do this immediately after the biopsy, but if they are hatching blastocysts, then we can afford. It depends on the work we have at the day, at the same moment. We can wait until an hour. And after the analysis and of course, we transfer the euploid blastocyst. So this is our data. This is quite, this is 97%, but it's a little higher now because it includes our first cycle, so it is including the learning curve. We are doing better now in survival. So this is the positive beta ACG, 67, clinical pregnancy rate 61, and 56 implantation rate. So this is low sample size, but we are doing quite well with TE biopsy and vitrification. And there are, of course, different studies in the literature showing consistent high survival rates after of biopsied blastocyst. But is it possible that there are some factors that are affecting survival rate of this TE biopsied blastocyst? This is a very recent and very interesting study. I recommend this study from Shang 2016. It was published in Fertility and Sterility. And they evaluate survival rate according to the TE score, survival rate and all of these parameters, according to TE score and the number of cells biopsied. So they had the grade E, grade A, B, and C, and these groups of biopsied cells. As shown by these authors, survival was not affected. No. Here is kind of low, but the sample size was lower here. So survival is not affected by maybe by the T quality and the number of cells biopsied. But implantation rate was higher in those high scored trophoctoderm.
And what about the size of the cells? The implantation rate is the same?
With more than 15 or so, no?
Eh?
With more than 15 in cells biopsy.
Ah.
Okay.
With more than 50. In the last talk. The last talk. So with more than 15, if it was a T score, 56 point,
56.9.
and it was 22.2 versus 52 for grade B. I mean, it seems that if it's grade A, there is no impact according to the number of cells biopsy. But if they are low quality score, then which is kind of logical as well. Yeah, this is the experts. I am not a PGS expert, so whatever you say. Yeah.
No, really, we need to.
But they did quite large number here. But what is also great, very interesting, is that according to the embryologist doing the biopsy, and according to the different score of 4GE, there were differences in the what is the parameter we are? Yeah, according to the embryologist, there were statistical differences in the number of cells biopsied with regards to the quality. So the hands are very, very important here. And it was also the same thing for the diagnosis failure. So there were differences between the operators. But it's not that I don't care about this, but my thing is vitrification. So, oh, sorry, before that, this is another study from Capalvo, 2015, showing that there were no any impact on different people doing the biopsy in terms of the diagnosis or in terms of clinical outcome. I was talking to Carmen Rubio from our group about this, and she says that maybe this group, it was from the study. The study group was the patients were from the same clinic, but in our case, or egenomics or igenomics, how do you say? Igenomics, you do this analysis for many clinics, and it is certainly an effect of where the samples are coming, at least the diagnose, the outcome of the diagnosis. And maybe Capalvo is not seeing this because it's a very controlled and a very controlled.
Probably high expertise.
Yeah, yeah, and it's a very controlled. Yeah. Yeah. And this is what I was showing, trying to show, that this is from our group, that survival for this T biopsy blastocyst is not related to the operator, to the people doing the vitrification. So it seems that it's much more difficult to do the biopsy than to vitrify it. Yeah. I can tell. And this is the last thing I wanted to share with you, which is the revitrification. With this PGS diagnosis, sometimes, or I would say very frequently, we are forced to do weird things. We need to vitrify, then warm, then vitrify again at different developmental stages, and I'm going to show you some results. We published this in 2013, in which we evaluate the outcome of the transfer of day 3 or blastocyst embryos, which were developed from vitrified oocytes from our ovum donation program. And we compare this versus the transfer of cryopreserved day 3 or blastocysts, which were developed from fresh oocytes. So as you can see here, survival rate was quite comparable between both groups. It means that revitrification does not affect survival rate. And for delivery rate per warming cycle, it was also comparable between the revitrification and the vitrification group for day 3 or for blastocyst stage embryos. So at least when you vitrified embryos developed from vitrified oocytes, it doesn't have any effect on the survival or delivery rate. There are different studies showing that we can revitrify either M2 oocytes, early cleavage, or blastocysts. This time is revitrified these cells different times. And there are all these studies show demonstrate that this revitrification is not affecting either the survival or the clinical outcome. And this is a study, again, from, this one was from, this one was from Grifo, again, showing that we can do whatever. So they did all these kind of things. And as you can see here, the survival or the clinical outcome is not affected. So revitrification is an option, so you don't have to be afraid if you need to revitrify any day 3 oocyte or blastocyst stage. And finally, I would like to give you some clues, some small little tricks which have been really useful, which we have learned when we started to vitrify the TE biopsy blastocyst. So we use the Kitasato protocol, which maybe most of you are familiar with this. And I'm going to give you some tricks in the different steps that are involved in this in the technology. So for the equilibration step, you remember we have the equilibration solution, 300 microliters in a wheel, and this is what we should expect. So this is the blastocyst. When it becomes in contact with the ES, then it will shrink, and then it will gain the cryoprotectant and will re-expand again. So this is what we expect. What we need to do at this time? Timing, as I mentioned before, we prefer to do this immediately after the biopsy, but we can wait until within an hour, especially if they are hatching blastocysts. If they are fully hatched blastocysts, then we do this immediately. We need to pay attention to the capillary diameter. It's very important, depending on the expansion degree of the blastocyst. So we use, and this is what we do, 275 when we move from the culture dish to the ES well. I have to say that when we do this, there is a mineral oil which enters the capillary. So we remove this capillary and put a new one, because it is the inner, the diameter becomes narrow because of this mineral oil inside. And we use 200 to 75 to move from ES to BS, which is the vitrification solution. If they are initially hatching blastocysts, then we give them a laser pulse to collapse them a little. Only if they are hatching. If they are not, we don't do this. And this is very important. When they are here, you don't need to move, you don't need to touch, you don't need to do anything. You put them, you leave them on the surface, and they will drop. They will, as they are gaining the cryoprotectant. Don't do anything, because this is very stressful for them. They are already biopsied. They are a hole in the sauna, and they are the exchange between water and cryoprotectant. It's a huge thing that is happening across the cell membrane. So you don't need to touch. It is pointless. It is dangerous. So at the vitrification step, this is what we, no, first here. This is what we do. We move from the ES to the vitrification, and what we do with the capillary is to move them at different places of the wall to wash them. The purpose of this step is to completely eliminate the ES solution that we are carrying in our pipette. So this is what we do. And I have to say that these videos are from regular blastocysts. These are not biopsied blastocysts. So this movement with biopsied blastocysts, we need to do this much more gently. Sometimes, and especially for initially hatching blastocysts, instead of moving this way, aspirating and dropping them, we pour solution, and then they roll. So we don't touch them. This is better. So we need to pay attention to, this is what I was telling you. Prevent them to extrude completely the zona pellucida. So for that purpose, we roll them instead of doing this. This is for regular blastocysts. I'm sorry I didn't have any video of biopsy blastocysts. For fully hatched blastocysts, they are too sticky. So we need to use a wide diameter to avoid them to stick to the capillary. And for us, it's a very useful trick. We manipulate them together with the empty zona pellucida, because at warming, it will be a very useful thing to locate at first the zona pellucida, which is much more clear than the blastocyst itself, that sometimes is very collapsed and it could look like an artifact. So if that thing is together with the empty zona pellucida, it's a good thing to locate them. So this is what we do. Yeah. And again, pay attention to the diameter of the capillary. And as I said, to prevent them to stick, for fully hatched, we use the 300 capillary. For the loading step, and again, this is not a biopsied blastocyst, I would say. Let me, oh, no, sorry. I just wanted to stop this at the, no, this is too much. No, maybe like this. For biopsied blastocysts, this is what we do. We leave them, as Nuno mentioned at the beginning, some more, because otherwise they could leave the zona pellucida, come out the zona pellucida, or stick to the capillary, and will be very difficult to retrieve them at warming. And maybe you could induce mechanical damage by doing this. So this is what we do. And let me if they are not biopsied, this is what we do. This is completely dry. And for biopsied blastocysts, is not good. So this is what I'm telling you, a little more vitrification solution to prevent them to leave the zona pellucida or to stick to the to the surface of the cryotop if they are fully hatched. For hatching blastocysts, we aspirate them from this side, the opposite way, because if we aspirate it from here, then they will, they will come out. And this is what I was telling you. For fully hatched, we load them together with the empty zona pellucida.
Like a reference.
Like, yeah, it's a very good trick. And this is also what we are doing now. Before doing the vitrification procedure, we take a picture to know somehow what we should expect at warming. What was it look like? And this is the last one, I think, for hatched blastocysts. At warming, again, we locate them close to the zona pellucida. This is a real picture. This is how they look like immediately after warming. Sometimes, and especially if you are not so expert, this could look like an artifact. So this is a very good idea. When we are in the TS solution, which is 1 minute 37 degrees Celsius, try not to recover them before 40 seconds. Again, as I mentioned before, the osmotic stress is very high at this point because there is water coming inside the cell and cryoprotectant going outside. So at this time, you don't need to add any extra mechanical stress. So as this is 1 minute in this point, you don't do nothing, just keep an eye on them before 40 seconds, and then pour some TS media over them, and never aspirate directly because you could damage the embryos. Avoid any strong manipulation, of course, and if you have the chance, check for the re-expansion after warming. And this is a real case, as I mentioned. This is the expanded blastocyst after, in this case, almost 4 hours after warming. And those are, it's working here, yes. Some time-lapse videos of, these are, this is the fully hatched blastocyst. And those are immediately after warming, and then we put this on the time-lapse. And 3.2 hours in this case for re-expansion and initial hatching. Same for this one. And this was fully hatched. And this time the doctor came too late. This is not for any other reason. And this one is usually late for transfer.
And the umbrella is white.
But it also carries good things, so we can check for the expansion. So in conclusion, vitrification has greatly contributed to PGS programs, making them more flexible and allowing the establishment of new approaches as this trophectoderm biopsy. Vitrification does not increase aneuploidy rates in embryos originated from vitrified oocytes, and survival after trophectoderm biopsy is not related to the operator doing the biopsy or the vitrification procedure. And I just wanted to thank my cryo team and the people doing the biopsy and doing the analysis. And thank you very much for your attention.